So we will now turn to Dr. Brawley. And if you have questions, you can raise your hand, and when Dr. Brawley is done, we will then turn to turn the microphone over to some of you, or you can submit questions in the Q&A, and I'll read those out. But Dr. Otis Brawley, tell us about COVID-19 and disparities in health, and particularly how it played out in the U.S.
Thank you. It's a real pleasure to be here, and it's a special pleasure to be here with Sir Michael. I'm a professor at Johns Hopkins University, and by way of disclosure, I do some consulting for the U.S. government and some consulting on accrual of clinical trial for Genentech. I wrote a book a few years ago. My talk is not really about the book. Indeed, my talk is about something that none of us envisioned when the book was written. I'm going to describe the COVID-19 pandemic, describe disparities created by it, and then disparities both in coronavirus and in other diseases. Much of my talk and much of my data is US-centric, but I suspect the patterns shown transcend to other countries, and indeed much of what Sir Michael talked about really does apply here. The COVID-19 pandemic, according to the Johns Hopkins Coronavirus Resource Center, as of yesterday, 29.6 million global cases, 936,000 deaths. In the United States, 6.6 million cases, and closing in on 200,000 total deaths. I'll note that the US is 4% of the world's population. However, we are 21% of the world's coronavirus deaths. I prefer to look at deaths from disease in rates per 100,000, and usually like to look at them in age-adjusted rates, but because this disease is so new, we don't have age-adjusted rates yet. But here are the death rates, crude death rates, deaths per 100,000 population for a number of countries. And you can see the United States is actually 7th overall in terms of reported death rate worldwide. And many of you are able to look and see what other countries in your regions are experiencing right now. Among people who are diagnosed with the coronavirus, the percent that die vary markedly. 10% of people diagnosed in Mexico versus 1.6% of people diagnosed in India versus 3% of people diagnosed with the coronavirus in the United States. Now, this statistic is of those diagnosed, and if there's less screening and less diagnosis, and a number of cases in the United States, for example, likely are undiagnosed, these statistics have to be taken, as we say in the States, with a grain of salt or some skepticism. This is the number of deaths for leading causes of death in the United States in 2019, and you will know heart disease followed by cancer, followed by accidents. With our 200,000 deaths from coronavirus, something we didn't even know about in January of this year, is now the 3rd leading cause of death in the United States. Every year, by the way, for the last 60 or plus years, cardiovascular disease followed by cancer has been 1 and 2. The disease was first introduced in the United States, affecting a number of large cities, New York City especially, Detroit, Chicago, New Orleans. The disease was and is disproportionately affecting poor and working class people who don't have the luxury of social distancing because of work conditions and living conditions, as Sir Michael pointed out. These people often suffer from the chronic diseases of poverty as well. They have higher rates of diabetes, hypertension, obesity, and one can also add cardiovascular disease and even cancer. And the poor and working classes are least likely to be able to obtain the health care that they need. This taken all together creates what I'll call the perfect storm for death in this pandemic. Socioeconomically deprived, often minorities, are the most likely to get disease. the most vulnerable to it and to the causes of it, and the least able to deal with it. Healthcare systems in specific areas of the United States were overwhelmed. And this interferes not just with the quality of COVID care, but it interferes with the provision of normal non-COVID care. I cannot overstress that people were harmed who had nothing to do with COVID. People had difficulty getting care for their diabetes, their hypertension, and other diseases. Now, how can we provide adequate, high-quality care to include preventive services to populations that so often don't receive it? Is, I think, the most important question we can ask ourselves in healthcare, and something we really should try to dedicate ourselves to. And minority and underserved poor populations are the most likely to go without adequate care, and that is the norm. In the setting of coronavirus, it's just accentuated. When the shutdown in the United States occurred, nearly 27 million people found themselves newly uninsured. 16 states in the United States have not expanded Medicaid under the Affordable Care Act. And this meant that in those states, adults under the age of 65 found themselves without any insurance and had to fend for their own. Even in states where there is the Affordable Care Act and Medicaid expansion, there were significant declines in the advent of the coronavirus pandemic, and even to this day. We have declines in the diagnosis of heart attack, stroke, diabetes, as well as cancer, and a number of diseases. People simply are not coming to the doctor because of fear of exposure to COVID in hospitals or physician offices, as well as fear of exposure to COVID in transportation to get health care. The shutdown in the United States, the decline in people getting health care, has actually been estimated through mathematical modeling by the U.S. National Cancer Institute that it's going to cost us at least 10,000 deaths in colorectal and breast cancer alone by the year 2030. And the number increases every year up to 2030. Now, the major reason for this loss of life from just colon and breast cancer is not is delay in treatment of known disease. It is not delay in failure to screen. It's the delay in people who are known to have these diseases or know they have a problem to go to the doctor and either get treatment or to continue treatment. And of course, the socioeconomically deprived are the most likely to suffer and most likely to drop out of care. Now, I should point out that the U.S. collection of data, especially race data, has been less than adequate. There's even been some allegations that the administration is trying to suppress the data or suppress the collection of the data. However, it is true that the pandemic in the United States today has disproportionately affected Blacks, Hispanics, and Native Americans, both from COVID itself as well as from the disrupted health system. That being said, I should point out that there has been some exaggeration of the effect on racial minorities. This exaggeration was trying perhaps to bring light on the plight of minorities facing disparate health care. In retrospect, it also may have caused some politicians to further ignore the pandemic. Let me give you one example. Highly cited in Michigan, 14% of the population is Black. 41% of those dying from COVID are Black. And those statistics are absolutely true for the state of Michigan and were absolutely true for the state of Michigan well into May. But it also can look at it another way. The disease was worse in 3 counties that make up far southeastern Michigan. 81% of all Michigan's COVID deaths occurred in those 3 counties. 68% of the state's Black residents lived in those 3 counties. 32% of the people in southeastern Michigan are Black. And it is very appropriate to say in southeastern Michigan, not all of Michigan, but southeastern Michigan, where the COVID epidemic was, 32% of the population was Black and 44% of those dying are Black. But in the press, we heard 14% of people in all of Michigan are Black, and 41% of people in all of Michigan who are dying of coronavirus are Black. Both are true, but 32 and 44 doesn't sound as dramatic as 14 and 41. In summing up, it is true that the pandemic today has disproportionately affected minorities. And the minority populations are most affected due to socioeconomic deprivation and not to some biological difference that makes them more likely to get the infection. It's really working environment, living environment. Now, as U.S. society is opening up, there are and will be increasing numbers of COVID infections in suburban and rural United States. The racial disparities in infection at that point are actually going to decrease, but there will still be disparities by socioeconomic status and deprivation. These, again, people who cannot practice social distancing and have work that requires it. So we're going to see, and we already starting to see, increasing numbers of poor whites with the coronaviruses. Now, populations with high prevalence of comorbid disease will also continue to have higher COVID mortality rates. And unfortunately, those comorbid diseases tend to be higher in poor populations. Now, in surveys, screening and health maintenance clinic visits are 70 to 80% of their pre-COVID levels. This includes the new phenomenon of web-based healthcare visits. The people who are not participating in routine healthcare are, again, the poor, the socioeconomically distressed, and those who tend to get their healthcare in emergency rooms and urgent care centers. And there are and will be localized shutdowns of healthcare provision due to outbreaks. This really portends to a decline in population uptake of necessary non-COVID related care and a rise in death rates from chronic disease. Disparities will increase as populations most affected will be the most vulnerable and socioeconomically deprived. Many of us have heard this wave analogy when it's talked about coronavirus in the population. The analogy that we should be thinking about is thinking about the ocean, where there are a number of different waves in a number of different places, and geographically we're going to have higher levels of infection, and the pandemic is going to be far worse in certain areas at certain time and better in certain areas. And I thank you. I'm more than happy to talk to anyone who might have any questions. Thank you very much.